All right, coming to you from the great outdoors today, birds chirping in the background. We're going to talk about digestive function. The GI system is pretty big, but at the same time, I think that it's something that we can kind of relate to. Some of these, conditions we'll talk about, maybe you've experienced before in your life or know someone who has experienced them. Um, if we think about the purpose of the GI system, we can kind of deduce that some of the problems that people have in response to some of these diagnoses are going to include things like nutritional concerns or absorption issues, which kind of relates to overall nutrition, and pain is going to be another one. Elimination and that kind of thing. So I guess those are some basic kind of nursing ideas to consider as we're going through digestive function. Make sure that you've reviewed your anatomy and physiology. I think chapter 56. I'm not 100% sure on that, but the chapter that talks about assessment of the GI system. There's a lot of good information, a lot of good tables and charts, things like that in that chapter. And it also goes into some good descriptions of different types of tests that might be done, whether that be procedures or radiology tests or labs or things like that. So just some things to make sure that you've looked at and have an understanding of as we start to dive a little bit deeper into the GI system. And just, like as I was saying in the beginning there, just sort of relate some of these things to maybe what you already know, maybe what you've already personally experienced with, GI discomfort or elimination, absorption issues, nutritional issues. That's kind of what we're going to be going through here today. So the first thing we'll do is we'll move into the stomach. This is something we'll talk about is called gastritis, and as we remember, that itis really means inflammation. And in this case, we're talking about inflammation of the gastric mucosa. Now, with gastritis, it can be very short term or acute. Some of us have probably experienced acute gastritis in our lives. Maybe, we ate some bad food or something really spicy or had too many, I don't know, adult beverages. But those types of situations have led to an irritation of the gastric mucosa and have resulted in some uncomfortable types of symptoms. Now, gastritis can also be chronic, and in those types of situations, an ongoing an ongoing continued assault of the gastric mucosa can eventually lead to changes within that tissue. Now, we know that the stomach is, responsible for, secreting things like gastric acid that helps to break down and digest the food and, kind of pull out the chemical components that our body needs to maintain nutrition. So if we alter those cells because of chronic irritation and changes within those cells, we start to see dysfunction in what what the stomach is supposed to do. It can maybe alter gastric acid production, or the ability to excrete intrinsic factor, leading to types of anemia, various different things like that. Now, because the stomach is a place where a lot of absorption occurs and kind of takes place, it is a very vascular organ. So because of that, when we start to wear away or irritate the protective mucosal lining of the stomach, those that very vascular surface can become exposed. And those vascular components are not meant to be directly exposed to the acids that are produced in the stomach. So we have a potential for erosion of those vessels to occur, leading to things like uh, bleeding. They can be very significant, if we're not careful. Really, when we talk about acute gastritis, that's those situations when we have ingestion of irritating foods, probably over a period of time, and we've just continued to ingest those irritating substances, and we're not allowing for an environment in which the stomach can heal. And that's kind of something to consider when we start thinking about interventions for our patient who's experiencing gastritis. Um, when we go down that line of thought, we want to create an environment where this lining can heal. Acute gastritis can also be a complication of different acute illnesses like traumatic injuries, severe infection, major surgeries. In these types of situations, not only is the body stressed out, but it's also trying to deal with other maybe more important problems to maintain hemodynamic status. And so the stomach can, kind of get left behind and left to become irritated. So several different types of diagnoses can lead to gastritis. Certain medications that we might give in the acute care setting or even take in the community setting can lead to irritation. And we have to consider that when we are caring for these patients, like medications that we give them. We know that NSAIDs, aspirin, these kinds of medications can lead to irritation of the stomach lining and contribute to gastritis. Corticosteroids is another one that can lead to irritation. And of course, just stress. When we think about that idea of patients in the hospital, mentally being stressed, physically being stressed, it puts these patients at risk for not just irritation, but ulcers. And so you'll find that most, if not all, of your patients in the acute care setting will be on some kind of proton pump inhibitor like Protonix, and we'll talk a little bit about that. Again, chronic gastritis, that's where we have that prolonged exposure to these irritating substances. The tissue is never really provided an environment in which it can heal, and we can start to see changes in the cells, like the cell types within the stomach. With these more chronic forms of gastritis, you're more likely to see certain types of anemia, like a vitamin B12 deficiency. That's also known as pernicious anemia, because those cells in the stomach that have to do with intrinsic factor are altered because of like scar tissue sort of situations. And therefore we can't absorb the vitamin B12 that we need because of the lack of the production of intrinsic factor. H. pylori, that stands for Helicobacter pylori. This is a type of bacteria that can lead to gastritis, and we'll talk a little bit more about that here in just a couple of slides and dive into that a little bit deeper. So what is your patient assessment going to look like when they are experiencing gastritis? Well, again, these are probably things that we may have experienced ourselves if we've eaten, I don't know, some, sort of bad food, or ingested too much alcohol, or kind of been overdoing it on, NSAIDs or something like that. So nausea and vomiting, maybe some weight loss or decreased appetite. Excuse me, patients might experience pain, especially pain that's made worse by ingestion of irritating substances like I don't know, spicy foods or something like that. We start to have more pain. Now, as that irritation becomes more significant and we start to get to the point where we're irritating the blood vessels in the stomach, we could also see some assessment findings that correspond with bleeding. And as you recall back way from the beginning of the semester, when a patient starts to have hemorrhaging, we can see some systemic manifestations of hypovolemia, basically because of hemorrhaging, with things like tachycardia and hypotension, maybe orthostasis, and that just really depends on how significant the bleed is. If a patient, it does have bleeding in the stomach, it might be visible in a couple of different ways of our patient assessment. If they're vomiting, you may see some kind of bright red blood in the emesis, or if the blood has kind of been allowed to sit in the stomach and kind of be partially digested and get kind of old. When a patient vomits, they may have something called hematemesis. I think that's how you say it, but commonly we might refer to that as coffee ground emesis. More likely when an ulcer actually develops, but I suppose you could see this with some ongoing gastritis. Now, the other way that we can visibly see blood from the GI system that's occurring in the stomach would be a change in the color of the stool. Now, if you think about the amount of time that things kind of have to pass through the GI system, they go from the stomach to the small intestine to the large intestine and then exit out. That's, kind of a long time. And if the stomach is bleeding, as that blood is digested through those portions of the GI system, by the time it exits the body, it's going to be very dark in color. So that's why we see black stools, because it's old blood. When we're assessing a patient's stool for blood, that's one way that we can kind of determine that perhaps we're dealing with what's known as an upper GI bleed, because it takes a longer time for that blood to make its way through the system. Now, there are other things that can turn a patient's stool dark colored. For example, iron supplements can make a stool look really dark or kind of a greenish color. So we might get something called a fecal occult blood test. So we can't visibly see necessarily that it's like a bright red blood or something like that, but we can test the sample for basically invisible blood or occult blood. And that might be something that we do for a patient that we suspect is bleeding because of an upper GI irritation, such as gastritis. Diagnosis isn't exclusively based on clinical symptoms, although it might be, just depending on whether you're dealing with an acute form of gastritis or a chronic form of gastritis. If we're looking at a more significant irritation of the stomach, we might see a provider order like an upper endoscopy, like an EGD. That stands for esophagogastroduodenoscopy, and basically that's an endoscopic test where they take this like flexible, I think it's like a fiber optic maybe tube that goes down the esophagus and into the stomach, where they could actually visualize the tissue, and in that instance they would be able to see that the stomach lining is irritated. The kinds of things that we're going to do for a patient dealing with gastritis is really just supportive care for the most part, and that includes, staying away from those irritating substances. We probably do this a lot naturally. If our stomach is feeling a little like irritated because of maybe something we ate or something we drank, we kind of back off on the foods that we choose to put into our bodies, because of that. Maybe we eat a little bit less, maybe we ingest things that are easier on our stomach. So that's kind of what we're thinking about when we're implementing treatment for patients with gastritis. Um, One thing to consider is just overall GI rest for a period of time, 6 to 12 hours, maybe NPO for a little bit, and then kind of slowly reintroducing substances into the stomach, maybe starting with clear liquids. Those are going to be less irritating. Um, Depending on the liquid, you don't want to be throwing orange juice in there because that's pretty acidic, but things like different types of broth or tea or gelatin, those can be tolerated a little bit easier. Not as much work for the stomach to have to deal with. And then maybe increasing that diet as the patient is tolerating it. Maybe some heavier liquids like cream-based soups and puddings, things of that nature. And then as the symptoms start to subside and the patient starts to feel better, we can slowly reintroduce more solid foods. In those instances, when we get to that point, still encouraging avoidance of irritating substances, things that are very acidic or things that are spicy. That's going to help provide the environment that the stomach needs to heal. Healing is pretty spontaneous unless it's a very severe form of gastritis. We just really need to provide the right environment so that the body can kind of take care of itself. But typically after a few days, you're kind of back to normal. There are some medications that a patient might be prescribed that can help relieve the pain and discomfort associated with that irritated stomach lining and the constant exposure to gastric acids. One class of those medications are called proton pump inhibitors. You might hear them abbreviated PPIs. These are medications like pantoprazole, that's Protonix, or I think lansoprazole might be Prevacid. Some of these you can get over the counter just at your normal pharmacy. Others you have to have a prescription for. But you can identify these medications because they have the ending of prazole. Those medications pretty much stop the production of acid, not completely, but a large amount. I don't even know what the percentage is, but it's pretty much stopping the production of acid in the stomach. So it's helping, again, to provide that environment that's necessary for healing. Another class of medications you might see utilized is something called an H2 antagonist. That stands for histamine. Now, we talked about histamine as it related to allergic reactions. This is a different, classification of histamine. They work on different, receptors than what proton pump inhibitors, but the end result is very similar. H2 receptor antagonists also decrease the amount of acid that's being produced in the stomach. These are things like ranitidine, which is Zantac, or cimetidine, which is Pepcid. They have that common ending of tidine. That's one way that you can recognize that it is an H2 antagonist. And again, many of these are available over the counter that you can just pick up at your local pharmacy or whatnot. There are other types of things that we can use that help kind of buffer the acid. They don't really stop the production of acid, so they're more of like a, I don't know, they don't really get rid of the problem, but they can help with the discomfort. That would be things like your antacids, things like Tums and Rolaids. These types of preparations use like a calcium or a magnesium sort of component to really just neutralize the acid. Again, they don't reduce the amount of acid that's being produced in the stomach. They just neutralize whatever acid is there. Unfortunately, with some of these preparations, like Tums or Maalox or something like that, a patient might experience rebound acidity. So the acid is neutralized, but then it kind of might come back even worse. I mentioned earlier a little bit about H. pylori, and H. pylori is a type of bacteria that is ingested unintentionally, of course, often through contaminated food and water. Many times patients, or people in general, I guess, might be kind of colonized, I guess you could say, with H. pylori, but they don't really have significant symptoms. And so it's not something that we really test for routinely. But if a patient is having persistent gastritis and the medications that we're giving to reduce acid, like PPIs and H2 antagonists, are not working, it might be worth considering, doing an EGD and obtaining biopsies to see if perhaps this little bacteria is the culprit that's causing the gastric irritation. Because H. pylori is a bacteria, it is going to be treated with a combination of 1 or 2 different antibiotics as well as a proton pump inhibitor. And so it's going to be important for patients to be able to be compliant with the antibiotics, because, we've talked about with infection that when people don't complete courses of antibiotics, they can develop resistant bacteria to those antibiotics, making it more difficult to treat that bacteria. There's a table, I think, in your book, maybe on page 1254. I don't know 100% if that's the correct page, but you should be able to find it close to the information about gastritis in terms of like what the treatment looks like for antibiotics and PPIs. In addition to, let's see what we've talked about. We talked about dietary changes, staying away from irritating foods and alcohol, a bland diet with non-spicy foods, avoiding those irritating medications like aspirin, NSAIDs, maybe eating kind of smaller meals would be helpful. Smoking is a vasoconstrictor, so avoiding smoking is also something else that we might do. Surgical management isn't really a routine treatment for gastritis, but if it becomes hemorrhagic, then we might have to do surgery on a patient. And that could include either a partial or a total gastrectomy. In other words, we kind of take out part of the damaged stomach that's causing problems. Again, that's kind of rare that something like that happens. They may also do a procedure that's called a vagotomy, where essentially they go in and they sever the vagus nerve that kind of feeds into the stomach, and that reduces the secretion of acid within the stomach. So just a few types of surgical procedures that you might see a patient with severe gastritis, undergo. And surgical care is surgical care, regardless of what the surgery is. We just have to be astute to the specifics, system that's being surgeried to help us focus on the types of things we might look for. But otherwise, it's just pretty basic surgical care that we've discussed in our perioperative section. So we'll move on to peptic ulcer disease, which is kind of almost a progression of gastritis. So as gastritis is allowed to progress, we can end up with ulcerations and erosions in both the stomach and or the duodenum. And the duodenum is part of, like, that first part of the small intestine where the pyloric sphincter at the bottom of the stomach kind of leads into the small intestine. So those tissues can become ulcerated. So in other words, they just have think about it like if you've had like a canker sore or something on the inside of your mouth, or if you liken it to like a pressure ulcer, like just kind of a little shallow divot, except it would be inside of your intestines, your stomach or your small intestine there. And this is, a much greater extent of irritation, I suppose, obviously. And so there's a higher risk for things like hemorrhaging. And that tissue is being exposed to those digestive chemicals, which it cannot tolerate that. And the patient can have pretty severe discomfort and high potential for bleeding and other kind of complications. So you see, again, that H. pylori can kind of be a culprit for the development of peptic ulcers. A lot of the same types of risk factors that we see with irritating substances like medications or smoking or alcohol ingestion, critically ill patients. So we see a lot of the very same types of risk factors for peptic ulcer disease as we see with gastritis, which kind of makes sense because it has to start somewhere. There has to be, like a level of irritation that produces, gastritis that ultimately leads to ulcers if it's not treated. Now, the pain that a patient experiences might be dependent on the location of the ulcer. And what I mean by that is if the patient has an ulcer that's a gastric ulcer, or in other words, in the stomach, then that person might experience pain that gets worse after they eat. Sometimes the pain can kind of radiate to the back or the shoulder. They might have some epigastric discomfort kind of right there in the center of the chest. This may even be mistaken as like a cardiac issue. They just the way that the symptoms can present. So might be kind of scary to patients. They have shoulder pain. We kind of hear about that with heart issues and that kind of thing. Now, if the ulcer is in the duodenum, or that first part of the the small intestine, then when they eat, their pain is probably going to get a bit better. So timing of the pain might give us some sort of indication as to where the actual ulceration has occurred. If that ulcer has blood vessels exposed, then the patient could experience GI bleeding. I kind of mentioned this prior when I was discussing gastritis. So, we think about other signs of bleeding, like hemorrhage, like hypotension, tachycardia. There might be a drop in a patient's hemoglobin. They might have, pallor to the skin, dizziness, like orthostasis, that kind of thing. And then if we were to examine, like, body fluids that come out, or excretions that come out of the patient, we might see that hematemesis, or we might see those black tarry stools because it's an upper GI issue. Now, if that ulcer is allowed to completely make its way through the stomach, then we have something called a perforation. That's a perforated ulcer. Patients will experience very severe abdominal pain that will quickly then lead to what's called peritonitis. And if you think about the peritoneum, is kind of that layer that is over top of all the organs in the abdominal cavity. And when it's exposed to something like an acidic stomach juices, it becomes inflamed and irritated, and a patient will have severe diffuse abdominal pain with a rigid board-like abdomen. They also will likely spiral downward hemodynamically pretty quickly because they are bleeding into their abdominal cavity. You can lose quite a bit of blood into your abdomen, before we actually see any, outward visible bleeding from a patient. So an abdominal distension might be something that you see with a perforated ulcer. This is going to require surgery. We're going to go back and think about those gastrectomies where we have to take out part of the stomach. Now, penetration, this refers to when the ulcer, the location of the ulcer in the stomach kind of starts to impact other surrounding like organs, and the ulcer starts to eat into some of those surrounding organs. I'm thinking of like the pancreas or something like that. So we can see evidence of ulceration there. And then lastly on here we have obstruction. And so as a damage to the stomach tissue is progressing and ongoing, the body's trying to fix itself and starting to build scar tissue, which is less compliant, which is more thick, and it can lead to obstruction to openings. So we have an opening from the esophagus into the stomach, and then from the stomach into the small intestine. So if those openings become narrowed, then we have an alteration in the way that stomach contents kind of move through the intestinal system. And if a patient has a a peptic ulcer, or we suspect that they have an ulcer, it's highly likely that they are going to get an upper endoscopy or an EGD. This is going to allow the provider to actually visualize through the utilization of a scope the stomach and the first part of the small intestine, so they can actually see the ulcer. If there is one there, they can see if it's bleeding or if it's, not bleeding anymore. But it's going to help to confirm that ulcers are what's causing the patient's problems and discomforts. If it is bleeding at the time of the upper endoscopy, they can, put clips there on those vessels to stop the bleeding, or cautery, or something like that. If your patient's going to be getting an upper endoscopy, they're going to need to be NPO for, I think your book says maybe 6 to 8 hours, because we want nothing in the stomach so that we can visualize the stomach and the intestines. So they're going to need to be NPO for a period of time. Prior to that procedure, they do get like a conscious sedation, so they're kind of awake during the procedure, but they're probably not going to remember anything. Probably something like fentanyl and Versed, maybe a little, I think sometimes they get Benadryl during these procedures, so that the patient can still follow the directions that they need to follow, and there's less of a risk involved when we're using more of a conscious sedation as opposed to a general sedation, and the patient's airway is no longer able to be protected independently. So some advantages there to conscious sedation. The other thing we have to consider when a patient has a procedure like an EGD is they are going to spray the back of the throat with some sort of numbing, like lidocaine sprays, to help facilitate the passage of that endoscope, which means that this patient is not going to be able to feel themselves swallowing. So once they have finished the procedure and the patient is starting to become more awake and alert, and is no longer sedated as heavily, before we can introduce anything, like for them to swallow, like even just water, we have to ensure that the gag reflex has returned before we can safely give them liquids or even food. A CBC, we've talked about that before. What we're probably looking at here is like a hemoglobin to see what their blood counts are. FOBT, that's a fecal occult blood test. So those are some diagnostic tests that you might see ordered on your patient. If we do find that a patient has a ulcer, then we have to create the environment that's necessary for that stomach tissue to heal. And so what we're going to do is we're going to take away those irritating type substances. So if they have been taking NSAIDs, then we're going to stop, those medications. They're not going to be taking those anymore. We will also implement dietary interventions like the bland diet, staying away from spicy foods or acidic foods. And really just promoting an environment in which the ulcer can heal. This is another place where we might see proton pump inhibitors or H2 antagonists. Another medication that you might see ordered for a patient with ulcers is a medication called Carafate. I think the generic name is sucralfate. This medication is given before meals and at bedtime, typically, usually about 30 minutes or so before a patient eats. What this medication does is it kind of coats the bed of the ulcer, so when food is ingested, which then stimulates the production of gastric acids, it protects kind of the bed of that ulcer from the secretion of acids out of the stomach there. So pretty similar interventions that we would do here again for peptic ulcers as what we would do for a patient with gastritis. It's going to take probably longer for these to heal, so therapy will probably be ongoing for a period of time, as opposed to maybe somebody who has just a simple case of acute gastritis. And again, if that ulcer perforates or is really bad, then the patient might require surgery, like a gastrectomy, things like that. It should be on the table in the basket. It's a little gold key.
Was it like round?
I don't know. It's key shaped.
Okay, thank you. That's all.
Uh-huh. Okay, so that is kind of the stomach part there. And we're going to move on and talk about gastroesophageal reflux disease. This is commonly referred to as GERD. You may yourself have experienced GERD at one moment or another in your life. Basically, what's happening with reflux is there is a sphincter at the bottom of your esophagus that leads into the stomach. And it stays closed until you swallow something and it goes into the stomach, and then it'll open and allow passage of the food. When that doesn't happen, when that sphincter is relaxed or weakened, or there's too much pressure from below, it can cause that sphincter to stay open, which would then allow reflux or regurgitation of stomach contents back up into the esophagus. After a period of time, the esophagus, like the tissue in the esophagus, becomes irritated and can kind of wear away, and it starts to have, could potentially have ulcers in it, just like with the stomach. That the esophagus is not meant to be exposed to gastric acid. So when this occurs over a long period of time, it can cause erosion of the esophagus. This is your classic heartburn. If you've ever had heartburn, this is what you have had, is GERD. It can be an isolated incidence or an occasional incidence, but for some people, it is ongoing. Here in the Western world, we have interesting types of diets, I guess you could say, where we have lots of big meals, lots of starchy foods, meat and potato kind of thing. And that can contribute to, some gastrointestinal problems related to this. Patients who have things like obesity or are pregnant, especially very pregnant, or ascites, which is an accumulation of fluid in the abdominal cavity. These things kind of increase the amount of pressure within the abdominal cavity, so it kind of can push up on the lower esophageal sphincter, thus allowing contents to backflow. Another thing about pregnancy is it doesn't have to be, I guess you don't have to be like super pregnant to experience GERD, because some of the hormones that are released into the body when you're pregnant cause a relaxation of the lower esophageal sphincter. So you don't really have to be super pregnant. Really just pregnancy can contribute to that. Tight belts or girdles, again, tight clothing, that's around the abdomen, can increase that abdominal pressure. NG tubes, you guys learn about that in skills lab, and that is a tube that goes down the esophagus and into the stomach, and guess what sphincter it has to pass through? The lower esophageal sphincter. So when we put a tube through that, the sphincter is not allowed to completely close, and so patients who have an NG tube are at risk for GERD because of that, because we're not allowing that sphincter to close. As I said, this is your typical heartburn. Some other things, though, that might not be so obvious in terms of what your patient's assessment is going to look like, could have very severe complaints of chest pain. Another one to think about, like, are we dealing with heartburn or are we dealing with some kind of cardiac issue? So it's not uncommon for patients to come in to the emergency department, let's say, and complain of like really bad, like epigastric substernal pain, and they get whisked away to the back of the emergency department and they get an EKG because they're trying to make sure that it's not a cardiac issue. Once they've ruled out that emergent potential problem and find that it is not a cardiac issue, then they can kind of think, okay, maybe this is, just some nasty GERD that's presenting with that atypical severe chest pain. Patients can have trouble swallowing. They might have issues where, if you think about gravity and you go to bed at night and you lie down flat, if that lower esophageal sphincter is relaxed, then whatever contents are in the stomach can kind of very easily backflow up into the esophagus. And if you consider the anatomy of the esophagus and its location to the I just had a brain fart, like what's the word, your breathing tube, right? They're right next to each other, and the epiglottis kind of closes down over our airways when we swallow. But when we're sleeping, all of that contents can kind of backflow up into the esophagus and actually make its way down into our lungs, and we aspirate stomach contents maybe unknowingly. Patient might report that they wake up in the middle of the night like very short of breath all of a sudden, not being able to breathe. They could get, an aspiration type pneumonia, become very sick because of that. Another thing to think about is when that stomach contents kind of reflux its way back up into the esophagus, it can start to irritate the vocal cords. The patient might complain of like just a chronic cough because that tissue is always irritated. They might have hoarseness when they wake up in the morning because those vocal cords are irritated. So some pretty atypical things that we may not always consider when we're like, oh, this is just heartburn. It can cause, some pretty significant other symptoms that we have to consider as well. Another thing that we have to think about is, as I mentioned, that esophagus is not meant to be continually exposed to gastric acid. And so as it is, the cells are killed and broken down and new ones are trying to be developed. They can develop like a type of scar tissue. So it doesn't always work the same way as the original cells do. And they can develop a type of tissue that leads to something called Barrett's esophagus. And basically that's what's happened. Is it's not normal cells that have been replaced because of this irritation and destruction related to the chronic exposure of acid. Barrett's esophagus isn't necessarily harmful in and of itself, but it is a known precursor to esophageal cancer. Also, the scar tissue is not as compliant as regular tissue, so we can again have strictures or obstruction. So patients might have trouble getting food all the way down. They may feel like there's food kind of constantly stuck there in their chest. They may need to have that esophagus kind of stretched out. Just like with stomach ulcers that occur in the esophagus can lead to bleeding. So very similar type complications when we're talking about esophageal damage as when we were discussing stomach damage, just it's happening in a different location. EGD might be a test that is done, especially if we're really concerned about the shape of the esophagus. We can also, get some testing. This esophageal manometry / motility testing tells us about, how the esophagus is moving and the function of the lower esophageal sphincter, that kind of thing. So we might do some sort of procedures or testing for severe GERD, but really we're going to be doing a lot of supportive treatment for the control of the acids. So again, you see some very similar medications here as to what we've already talked about, such as antacids, proton pump inhibitors, histamine receptor antagonists. If you think about this, these types of medications are going to either neutralize the acid or reduce the amount of acid that's being produced. And the acids are what are harming the esophageal tissue. So if we reduce the amount of acid that's being produced, then we can reduce the amount of damage that's being done to the tissue. Same kind of thing with dietary interventions. We might suggest that the patient eat smaller, more frequent meals so that they don't have as much food content in their stomach. We can recommend that they don't go to bed or lie down, 30 minutes to an hour after eating, just to help with gravity and promote digestion. If a patient has obesity, we might encourage weight loss to help reduce the amount of intra-abdominal pressure related to extra abdominal tissue. let's see, what else can we do? Avoiding, those acidic foods or foods that are going to promote more production of acid in the patient. Your book talks about several different type of non-pharmacological interventions that have to do with things like lifestyle and diet, avoiding certain types of tight clothing, things like that. A prokinetic medication, I guess we haven't discussed that. That kind of medication helps to move contents through the stomach. So if the contents are not sitting in the stomach as long, that they don't have the ability to kind of reflux back up into the esophagus, and that medication is metoclopramide, also known as Reglan. Surgery could be done. A Nissen in particular, I have a picture of a Nissen fundoplication here in a couple slides when we talk about hernia or hiatal hernia, so we'll talk about that a little bit more, but that could be a surgical procedure that your patient has done. All right, so moving into what we call hiatal hernia. Essentially, what has happened with a hiatal hernia is part of the stomach is allowed to either slide up the esophagus or roll next to the esophagus. So there's some sort of problem with the just the tightness, I guess, of the sphincters, the structure there, where the stomach is no longer below the diaphragm where it's supposed to be, but rather it's above the diaphragm. So those are your book talks about multiple types, but really we just focus on type 1 and type 2. So a type 1 hiatal hernia is also known as a sliding hiatal hernia because it slides up the esophagus. You'll notice that the types of symptoms that a patient with a type 1 hiatal hernia is going to experience are very consistent with what a patient with GERD might experience. That is because of the location of the hernia being above the lower esophageal sphincter. And so we have backflow of contents up into the esophagus. Now, type 2 hiatal hernia is also known as a rolling hiatal hernia. And basically that is going to herniate up through the diaphragm and roll next to the esophagus. So our symptoms aren't like GERD, rather they start to present like there's less space in the chest cavity, right? So if we have part of our stomach now in the chest cavity, we might feel kind of short of breath after we eat, feel very full very quickly, might feel like we can't breathe, or feel like there's chest pain after we eat. As we lie down, symptoms can get worse. So it's really all about the positioning of where that stomach is located, whether it's up inside the esophagus or over next to the esophagus inside the chest cavity. As you might imagine, a type 2 hiatal hernia is more likely to have a surgical intervention performed as opposed to a type 1. Oftentimes, patients don't even know that they have a hiatal hernia. They've probably just been getting treated for GERD until they get some sort of test like an endoscopy, like routine screening or persistent symptoms, and then the provider can actually visualize that the stomach is not completely where it's supposed to be, and they're like, oh, you have a hiatal hernia. They may get an upper abdominal x-ray. That might be something else that they look at. A barium swallow with a fluoroscopy. Basically, this is like a live action sort of x-ray or ultrasound or something like that. Patient drinks a substance that is able to be highlighted through this fluoroscopic technique, so you can see where it goes. So if it doesn't go down into the stomach where it's supposed to, but it's kind of hanging in the chest or up in the chest cavity, they can tell that the patient has a hiatal hernia. Again, EGD, I've spelled it out there for you, is something that's going to probably be useful in diagnostic of hiatal hernia. Medications are going to be utilized just like they were for GERD, if that's the type of hernia that your patient has. And then if they require surgery, then they're going to have a Nissen fundoplication. So basically what's happening with this surgery is they are taking the stomach, pulling it down to where it's supposed to be, and wrapping part of the stomach around the junction, the gastroesophageal junction, to tighten it up, so that it kind of keeps the stomach down and anchored in place where it's supposed to. You will notice when you look at the left stomach, which is in normal position, and the right stomach, which has had a Nissen, there is significant, it's smaller. The stomach is smaller, so we might have to encourage more more frequent smaller meals. There could be some absorption issues. There could be some anemia issues. So it's not, not without complications that we go into these surgical procedures. So just like with everything, we have to consider risk versus benefit. So just a couple of quick things here in the next 3 slides that we're just going to breeze through. First of all, hernias. Now, we just talked about hiatal hernias, and remember, that's when part of the stomach moves either up the esophagus or next to the esophagus, and it is kind of herniated through the diaphragm or that lower esophageal sphincter. When we typically hear patients say, I have a hernia, they don't usually say that in reference to a hiatal hernia. What they're typically talking about is what we see here. In this type of hernia, or an abdominal hernia, is protrusion of these abdominal contents through an area in the stomach where the muscle there has been weakened. They're relatively harmless. Sometimes they can cause discomfort. Sometimes they don't cause any discomfort. Oftentimes they can be reduced or kind of pushed back into where they belong. The danger with abdominal hernias like this is they can become strangulated. So basically, this portion of abdominal contents, usually like intestines, has pushed through an area of weakened muscle, and there's other tissues and stuff there, and if it becomes strangulated, the muscles and things kind of clamp down around the intestine, or maybe the intestine kind of gets twisted, and when that happens, we're reducing blood flow to that area of the intestine, and if the intestine it has no blood flow, then it's going to die. And so a strangulated hernia can be a medical emergency that is going to require surgery to repair that. So some sort of abdominal surgery with hernia repair. Oftentimes they place a mesh over the top of this to kind of keep it in place and provide that structure so it can't kind of break through the abdominal cavity like it did before. Hemorrhoids are basically swollen, dilated veins in the anal rectal area. They're caused by prolonged straining, such as with constipation, childbirth, heavy lifting, anything that causes increased intra-abdominal pressure. Hemorrhoids can be internal or they can be external. They can cause things like itching or pain or even bleeding. What you see in this picture would be what we might call a prolapsed hemorrhoid. If they go back in to the inside, then they've been reduced. Management for hemorrhoids typically is very conservative. We might use things to help with comfort, like cold packs or sitz baths or witch hazel. Creams and ointments might be used to kind of help shrink the hemorrhoidal tissue. This is where your preparation H and anusol and things like that come into place. Surgery is really seldom required unless there's thrombosis of the hemorrhoid, and basically what that means is the hemorrhoid has sort of been pinched off and it's not been allowed to get good blood flow, and whatever blood is in that swollen dilated vessel kind of becomes coagulated and clotted, and so it can be very, very, very incredibly painful. It can cause a lot of bleeding, as you might imagine, because hemorrhoids are at the very end of the GI system. Hemorrhoidal bleeding is bright red in color because it's not had to go through the whole GI system. You can actually see quite a bit of blood from hemorrhoids, so if that's the case, they definitely might require surgery, but sometimes they'll even, like what they call band hemorrhoids, so I think of this like what I imagine they do when they castrate animals. You know how they kind of like wrap a rubber band around it and cut off blood flow, and it just kind of dies and comes off. So they can kind of do that. You can see different types of surgical procedures that are used, I think, on page 1271 in your book. So here, IBS and IBD. IBS is a functional disorder of the intestines, really with no known etiology or cure. There may be correlations, or there, let me see, there's correlations behind certain types of things that lead to IBS, and theories behind what happens there, whether it's some kind of autoimmune disorder or if it's a genetic disorder or, you know, whatever. But these types of theories sort of drive the treatment that the providers are going to prescribe for IBS. Really, management is what we're going to do of these symptoms. Patients can either have what's called constipation IBS, diarrhea IBS, or a mixed, where they kind of sometimes will have constipation and sometimes will have diarrhea. So whatever symptoms the patient is experiencing, those are the types of symptoms that we are going to be treating with medication or diet or whatever the case may be. Stress management is another key factor in treatment of IBS. It's been shown that stress can trigger exacerbations of IBS. We might encourage high fiber diet because increased fiber is going to lead to bulkier stools. You can see a variety of different medications that are used in the treatment of IBS in your book on page 1275. Inflammatory bowel disease is really an umbrella term for these two chronic bowel disorders that are listed here. The cause is exactly, it's unknown, but again, some theories do exist. Exacerbations, again, are often precipitated by stress. You can see in your book on table 58.3 a comparison side by side for Crohn's disease and ulcerative colitis, and table 58.4 outlines the various drugs that are used in the treatment of IBD. A couple of things about these two diseases. Crohn's disease can affect any portion of the GI tract from top all the way to the bottom. It is more common in the terminal ileum and the colon, whereas ulcerative colitis affects the large intestine and involves only the mucosa and the submucosa. So why is that significant? Well, for us, I don't know that it necessarily is, but if we're looking at in terms of the types of interventions we're going to do, but if you're looking at, testing that the provider does, what they are going to see on a colonoscopy or an EGD, that might be significant in what they look at. The way that the tissue looks, Crohn's versus ulcerative colitis, is going to appear different, and that's going to help the providers with their diagnosis of what disease it is under this inflammatory bowel disorder umbrella. A patient with Crohn's disease can have complications like fistulas. So in other words, we have two like adjacent tissues that are growing together that shouldn't be growing together, and it just kind of develops into like maybe the part of the small intestine is growing with part of this large intestine or something like that, or part of the large intestine kind of becomes attached to something in the urinary tract and system. So that's kind of what a fistula is there. They can also develop abscesses. So in other words, we have little pockets of like infection that can occur within the intestinal tract. We can get strictures or narrowed parts of the intestine, or adhesions, which is basically a whole bunch of scar tissue that not only can narrow the lumen of the intestine, but it can also kind of, make it so it becomes completely strictured, like a blockage. Stuff can't get through. Diarrhea is not as severe as with ulcerative colitis, and with Crohn's disease, the pain is typically worse in the right lower quadrant. With ulcerative colitis, we often see high amounts of diarrhea, upward of 20 stools or more a day. It's also common to see blood and pus in the stool. And abdominal pain is typically worse in the left lower quadrant. And that these are lifelong issues that a patient is going to have. And so it's all about management, like long-term management and dealing with exacerbations when they do occur. And when a patient does experience an exacerbation, we want to rest the bowel and control inflammation. So, we might do that with dietary changes. Sometimes we might use steroids during exacerbation. Some of those biologic medications that we talked about with rheumatoid arthritis are also utilized in treatment here of these disorders. We also have to be concerned with nutritional deficits in these patients because the small intestine does a lot of absorption of nutrients and vitamins and things of that nature. And so if we have significant dysfunction within these locations, there is a potential for significant nutritional deficits and things of that nature for patients. So diverticulitis is a inflammation of diverticulum. Now, a diverticulum, that's plural for diverticula, and a diverticula is a little kind of outpouching of the large intestine. So normally when we think of the lumen of the large intestine, it's this smooth walled structure. And with diverticula, what happens is there's increased intraluminal pressure over a period of time, which then kind of pushes out a little piece of that structure, causing this little kind of like cave, I guess you could say. But because it's not supposed to be there, it originated from, the normal part of the intestine. That wall is weaker than the diverticular wall is weaker than the rest of the intestinal wall. Kind of like a balloon. When you blow up a balloon and it gets all stretched out, right, as opposed to one that's all deflated. Kind of like that sort of idea. Now, diverticulum in and of themselves are not harmful. They don't cause any type of symptoms or discomfort, but they do have the propensity to become irritated and inflamed, which would then cause symptoms that the patient might report. And then if we already think of an already stretched out piece of balloon and we inflame it, meaning we stretch it out even more, that wall of that diverticulum or of those diverticulum can become more weak and ultimately could kind of get a hole in them and sort of burst open. So we don't always see a rupture in a diverticulum when we have a patient with diverticulitis, but it's definitely something that we have to think about when we talk about complications of diverticulitis. Westernized societies tend to have more incidence of diverticulosis, which is just the presence of diverticulum, right? They're not inflamed, they're just there. Just because of the type of diet that's eaten in westernized cultures, the best thing that we can do is prevent diverticulum from even occurring, and this is why we encourage high fiber diets. Fiber adds bulk to the stool, and so when we have a larger, bulkier stool, then the intestines don't have to squeeze as hard to move that material through the intestines. If we have really, narrow, non-bulky stool, the intestines have to squeeze harder, so there's more pressure placed on the intraluminal walls, ultimately leading to diverticulitis or diverticulosis and constipation. If that stool is sitting inside of the colon and you're not getting like plenty of fluids and that sort of thing, again, we're causing increased pressure on the intraluminal wall. Patients are probably going to have some pain and discomfort abdominal distension, maybe bloating. Oftentimes they have left lower quadrant pain. This is where the sigmoid colon is. Or not even left lower quadrant, just the left side, I guess, if I think about the anatomy. A sigmoid colon is a little bit more narrow, and there's sort of a curve to it, and so it's higher likelihood that we could have increased pressure there. So it's more common to occur on that left side. Patients might also have an elevation in their white blood cell count if they have an infection present, but they don't have to have an elevated white blood cell count to be diagnosed with diverticulitis. Let's see, patient might report increased passage of flatus, anorexia or not feeling like eating, abdominal bloating or distension. They may even have diarrhea or constipation. Sometimes there could be mucus or blood in the stool. In the elderly population, we often see confusion as an early sign of diverticulitis. Now, if a perforation does occur, like I mentioned, that overly stretched out piece of balloon that's popping out there, if a perforation does occur, then we're going to see signs of sepsis as well as peritonitis. Remember, peritonitis is because the peritoneum becomes irritated and inflamed, so the pain, instead of being localized on the left side, might become more diffuse in nature, and the abdomen rigid. There might be a lot of guarding. The patient's really trying to protect the abdomen because of the tenderness. And they may have what's called rebound tenderness. So basically what rebound tenderness is when you push down on an area, it's not tender, but when you let go on the rebound, it causes discomfort. Other complications of diverticulitis include things like abscess formation, which is a pocket of infection, or fistula formation, where parts of the intestine kind of grow together that shouldn't be growing together. And then, of course, bleeding. Diverticular bleeding can be real nasty. It can be a lot of blood. If a diverticulum starts to bleed because of the location that it is in the intestine, it's probably going to be more of a maroon color because it's a little bit lower down in the intestines, but it's not all the way at the end like the hemorrhoids. As far as a provider diagnosing diverticulitis, in addition to symptoms that the patient is experiencing, the most common diagnostic tests are things like CAT scans. They can use that and see it. Of course, we may also do a colonoscopy. A colonoscopy is kind of like an EGD, but it goes in the other end. And this requires a certain type of preparation. The patient has to be placed on bowel prep, which means we are trying to clean out the bowel. Your book goes into really good detail about how a bowel prep is performed. We use high amounts of laxatives such as Miralax or Go Lightly. These are types of laxatives that draw water into the bowel, cause peristalsis to happen, and ultimately kind of to evacuate the bowel. The patient will have to start this type of preparation at least 24 hours prior to the scheduled colonoscopy. During the preparation, they need to be monitored for hydration and encouraged to drink clear liquids. They don't want to be eating food, right? We're trying to clean out the bowel, not add more to it. Clear liquids are going to just help keep the patient hydrated and help facilitate passage of fecal material as the whole bowel gets cleaned out. It's a very uncomfortable preparation because patients are just pooping all the time, and it can be with great urgency. A lot of times this is done outpatient at home, so we need to make sure that we're giving really good instructions about what they can ingest, how to go about drinking the mixture, whether it's magnesium citrate or phosphosoda or Miralax or whatever it is. They need to be instructed on that, and that they're going to be pooping a lot. But that's the goal. We want everything to come out. We will know that a patient is ready when their effluent is kind of like a kind of looks like chicken noodle soup. You can kind of see through it, but it's sort of a yellowish in color. If it's still dark colored, like brown and muddy looking, then that patient is not ready for their colonoscopy. That is something that needs to be communicated to the provider if you're getting ready to send the patient to endoscopy. Like, let's say you've done bowel prep all night long. It's 5 o'clock in the morning. They're supposed to go to their colonoscopy at 8. 5 o'clock, they've still got like dark brown, muddy looking effluent. You have to call the provider and let them know, because they are planning on doing that test on that patient at, in just a couple of hours. And if they're not ready, then they have to rearrange the schedule to accommodate that. And they also have to perhaps provide more bowel prep for the patient, whether that's additional intake of laxatives or an enema. It's common that we do like a tap water enema up to a couple of times until the patient's effluent is, clear, is ready. If the patient is not ready when we send them down, if they haven't been prepped appropriately, then the provider cannot visualize the wall of the colon, and therefore this patient has undergone this preparation for this test and this procedure and received anesthetics and all of these things, all for naught, and they're going to have to reschedule the test and do it all over again. So when it comes to bowel prep, it is important for the nurse to communicate the results of that with the provider if they are not ready by a certain time. When they go in and do a colonoscopy, they can actually visualize diverticulum. They can see if they're bleeding or if they have ruptured, things like that. So that's definitely a test that your patient, or a procedure that your patient might get. Now, not everybody who has a flare-up of diverticulitis is going to be in the hospital. Maybe a person was diagnosed with diverticulosis through, maybe a routine colonoscopy or something like that, or maybe they had a flare-up in the past. But now they're just experiencing some, symptoms that are consistent with diverticulitis. They may go into their outpatient provider and perhaps, be told, here's some antibiotics for you. Don't do laxatives, don't do enemas. We're going to give you maybe some pain medication. Let's back off on your diet and kind of see what happens after a few days. That's okay. That is something that can be done on an outpatient basis. Now, the patient should be admitted if they are presenting with a fever over 101. Their abdominal pain is severe and it's lasted for greater than 3 days, or they have evidence of GI bleeding. Now, once a patient with diverticulitis comes into your hospital, they will be NPO. That's bowel rest. We don't want to put anything into the system so that the system can be rested and it can heal. Because of that, they're going to get IV fluids because we want them to stay hydrated, probably some pain medications, and likely some IV antibiotics. They may have an NG tube for bowel decompression, but not necessarily so. We are concerned about electrolyte imbalances, fluid imbalances when the patient is in the hospital with diverticulitis getting treated for that. Again, no laxatives, no enemas, because this is going to increase intestinal motility. It's also going to increase the intraluminal pressure, which, if the patient doesn't already have a perforation, could actually cause a perforation. Complications like perforation, hemorrhage, obstruction, or abscess, they might require surgery to remove the diseased portion of the colon. This could just be taking out the piece of colon and kind of like putting back together the two ends. It could mean that they have a temporary colostomy replaced, where they divert part of the colon to the abdominal wall, and leave the rest of the colon kind of in place and try to allow it to heal, and then maybe go back in later on to reanastomose the two ends of the colon. As the patient in the hospital starts to feel better, their symptoms start to subside, they might be started on a clear liquid diet and taught to increase the fiber in their diet over time. But when someone is experiencing an exacerbation of diverticulitis, we want to encourage a low fiber diet. All right, this is a little bit different. For long-term maintenance of diverticulitis, we want a high fiber diet, because remember that bulky stool is going to decrease the amount of pressure that's exerted on the colon wall. But for an acute exacerbation of diverticulitis, we want a low fiber diet, because we're trying to rest the intestine and prevent irritation of those diverticulum. There is some evidence out there, you may be aware of this, where things like seeds or corn or nuts, things like that, can get trapped into diverticulum, which can lead to irritation, but that's not really conclusively so. It's not really truly proven. But you might see those recommendations from a provider for a patient to avoid those types of foods and things of that nature. All right, we're getting there. There's a lot to talk about with the GI system. A lot of things happen. Appendicitis is an acute inflammation of the appendix. This condition commonly occurs in children and teenagers. When it does occur in older adults, it usually ruptures and is much more serious. In the elderly, you're more likely to die from appendicitis if you're older. There really are no particular risk factors or preventative measures in regards to appendicitis. It tends to affect men more than it does women. So what's happening with appendicitis is, if you think about the colon, there's this little finger-like projection that's kind of off the side of the cecum. That's part of the colon. There really doesn't serve a lot of function anymore. There is some immune protection to the GI system with the appendix, but I think as we have evolved, it's not been something that's as necessary for our long-term survival. So if there is some sort of inflammation or infection, it's just safer to take it out. People used to die of appendicitis. And now, just removing it is not going to shorten somebody's life or anything like that. Let's see. So patients start to complain of pain kind of in the mid-abdomen area, and it gets worse over the following few hours and begins to localize in the right lower quadrant. That's where the appendix is at. If we were to palpate that region, a patient might have rebound pain in that location. For some reason, that location is called McBurney's point. They may also have pain in the left side when the right side is palpated. That's called Robson's sign. It's just because of the inflammation of the area, it causes that kind of referred sort of pain. Patients will also experience low-grade fever. They may have nausea, not feel like eating. Leukocytosis might be present. And if a patient has a sudden relief of their pain, this is an indicator that the appendix has now ruptured. That's not a good thing, because now all of those contents are leaking out into the abdominal cavity, leading to peritonitis, and the patient can become very gravely ill very quickly, and is going to require much more urgent surgery. So, something to kind of keep in mind there. Oh, there's pictures of McBurney's point and Robson's sign. Let's see if there are other things that I wanted to say about the pain. If the patient has increased pain with coughing or movement, or pain is relieved with bending the right hip or knees, that could be indicative of, what are we talking about? Appendicitis, sorry. This is a good patient that you might see a left shift on. Leukocytosis with a left shift. So really the only treatment for appendicitis is surgical management. There isn't really any medical management for this, other than treating the symptoms prior to surgery. So if a patient's suspected to have appendicitis, a surgical consult should be obtained as soon as possible, and the patient should be prepped for the operating room so that they can have their appendix removed. Now, this can be a varying amount of time depending on, how ill the patient is, whether, we think it's ruptured or not ruptured, that kind of thing. But, we want to keep the patient NPO. We want to treat their pain. We want to treat their nausea, get IV started, initiate IV fluids. No laxatives or enemas should be provided to these patients because that's going to increase the amount of pressure and could lead to a ruptured appendix. Oftentimes we think about like heat as a good non-pharmacological intervention for pain, but not in this instance. That is contraindicated for suspected appendicitis. Applying heat for these patients could actually lead to a rupture. Now, for the most part, once a patient has had surgery for appendicitis, the recovery is pretty quick. Now, if they did experience a ruptured appendix, they're probably going to get antibiotics and may even have to stay in the hospital for a few days. But if it's a kind of, not ruptured, surgery went really well, patient's healthy, and young, no comorbidities or anything like that, they may go home the very same day. So, pretty standard post-operative care for these patients: pain control, tolerating oral foods, drinking plenty of liquids, able to urinate, get up and ambulate, no nausea, have someone that's going to be able to drive them and take care of them, no signs of infection, stuff like that. So pretty standard post-operative care for these patients. They do have to be instructed about activity. They did still have surgery, so activity should be restricted. Things like lifting and exercising might have to be curtailed for a period of time until they follow up in a couple weeks at their post-operative visit. That's kind of a key thing to remember, because remember, the most affected group of patients here are 10 to 19-year-olds. They tend to be more active. So we just have to make sure that they understand that. Once they are beyond that post-operative period where they're, tolerating clear liquids and, food and stuff like that, there really isn't any dietary restrictions related to the appendix that we need to educate the patient about. All right, cholecystitis. I think this is our last thing. Cholecystitis refers to inflammation of the gallbladder. It also indicates that the patient has an obstruction in the flow of bile. So bile is made in the liver, and it is utilized for digestion of things like fats. And the liver will dump bile into the small intestine in response to the presence of these types of foods, but sometimes it's not needed right away, and so it's stored in the gallbladder, and that's basically what the gallbladder is a storage place for bile. And so sometimes what can happen is while that bile is in the gallbladder, it can form into stones. And when those stones develop, then they can obstruct the ducts that lead from that location into the small intestine where it's supposed to be poured out at. Right? When a patient has gallstones, that's called choledocholithiasis. That means stones in the gallbladder. When we're talking about cholecystitis, we're talking about inflammation of the gallbladder, which can be because of stones or not, but that gallbladder has been exposed to that bile and is irritated. Oh, for goodness sakes. I'm going to have to move. All of a sudden, we've decided that we need to do weed eating or something. Hold on. Sometimes patients who have cholecystitis don't have any types of symptoms. Other times they do. And when they do experience symptoms, it's usually and the right upper quadrant, because this is where the gallbladder is located, kind of tucked up underneath the liver. Patients might have like some guarding or tenderness in that area. They may experience signs of systemic infection like fever, tachycardia, things of that sort of nature. Nausea and vomiting is pretty common with cholecystitis as well. In order for us to know that a patient has cholecystitis, there's going to be some type of radiological exam. Your book talks about several. Usually, what I see in confirming cholecystitis is in a right upper quadrant ultrasound. This is going to allow the provider to actually visualize the gallbladder and kind of see if there are stones in there or not stones in there, and what, that kind of thing. CAT scans, you might also see an order for a CAT scan where we can detect the presence of gallstones. Another type of diagnostic test that's done is called a HIDA scan. HIDA stands for hepatobiliary immunodiazid, I don't know how to say it, acid scan. This is a nuclear medicine scan that uses a radioactive tracer to study the production and flow of bile. An ERCP is another type of common procedure that we see. It's called an endoscopic retrograde cholangiopancreatography. I did a horrible job at saying that. But this is an endoscopic procedure where they go in and they actually visualize the common bile duct. And at that time, if there are stones, they can remove the stones. Again, it's an endoscopic procedure, so just like we talked about with the EGD, the patient has to be NPO, and things of that nature. With these ERCPs, it does increase the risk for infection. And so when you're caring for a patient after an ERCP, you have to monitor them for signs and symptoms of infection. So just something to kind of keep in mind. We may see an elevation in our white blood cell count. We might see an elevation in our liver function tests, such as the AST, ALT, ALK Phos, and bilirubin. There's a good chart in your book that refers to these different lab tests that might be elevated. And other than the white blood cell count, I don't think any of these other ones are like gotta know for NCLEX type labs, like the values, but just understanding that if they're elevated, that could be an indicator of something. There's more what we need to sort of focus on with that. Pain is going to be something that we deal with. So there'll probably be NPO. They'll probably, let's see what else you see, antibiotics. Now, not everybody who has cholecystitis will get antibiotics, but I think most of the people that I've cared for do, especially if they have leukocytosis. Sometimes, in fact, they will delay taking a patient to surgery if the plan is to take the gallbladder out, if they have a really high white blood cell count. They'll call that, they have a hot gallbladder. They want to give antibiotics on board to try to get that infectious process under control before they go cutting on the patient and maybe making the infection worse. Another one of those risk-benefit types of things. If they're nauseous, we deal with nausea. If they have pain, we deal with pain medicine. But ultimately, it may be decided that the patient is going to require some sort of surgical intervention. Let me see. I guess I should tell you about foods too. Talked about NPO, IV hydration, potential for fluid and electrolyte imbalances, pain management, IV antibiotics. Talked about a hot gallbladder. I'm just reviewing my notes. Oh, for pain, morphine is usually contraindicated for pain management because it can cause the spasm of one of the sphincters that's kind of down in there. Fatty foods like fried foods, ice cream, dairy products, red meat, and alcohol should be restricted because they promote gallstone formation. We can encourage intake of certain foods like rice, potatoes, pasta, yogurt, fruits, lean meat, and whole grains. Those are foods that are low in saturated fat. Okay, moving on. Surgical management. So we have a couple of different things that we can do to take the gallbladder out. We can do what's called a laparoscopic cholecystectomy or an open cholecystectomy. Basically, what we're doing is we're going in and we are taking out the gallbladder. Again, this is a little organ that you can live without, just like the appendix, right? The preferred method is laparoscopic. Laparoscopic uses several small incisions in the abdominal cavity, and they use a machine to kind of, like a robotic machine, to kind of go in there and cut out the gallbladder and resect it and get rid of it. Part of that procedure includes injecting like CO2 gas into the abdomen, so it kind of can puff up the abdomen, so there's more room to kind of work in there, and better visualization is allowed by doing that. I say that because it is common and expected when a patient comes back from a laparoscopic cholecystectomy that they have some abdominal distension and they have some shoulder pain. Because as that gas is trying to make its way out of the body, it rises and puts pressure on the shoulders, so the patient might experience shoulder pain. And then, of course, it's distended because they kind of pumped that gas inside of the abdominal cavity. The best thing that we can do to help alleviate that is have the patient get up and walk. That's going to help those gases to dissipate, be absorbed, and excreted out of the system. Let's see, other post-operative care. I mean, they're going to be really little incisions. They're probably going to have Band-Aids over them. Patient is usually okay to shower, 24 to 48 hours later. They'll leave the bandages in place. Once they do take the bandages off, they're going to see a couple of things. Either steri strips, which they need to just leave those alone. Don't peel them off. They're kind of helping to hold those little incisions in place. There may also be like surgical glue on there as well. Or they might see sutures. Now, if a patient does have a couple of stitches in those incision sites, then when they follow up with their provider, they'll have those sutures removed. No lifting anything over 10 pounds until they follow up with their provider and get clearance on that. Clear liquids for about 12 hours after the procedure, and then we can increase that diet as tolerated towards a low-fat diet. Remember, we've removed the gallbladder, so there's an alteration in their ability to digest fatty foods. In fact, if they do ingest a lot of fatty foods after they've had this procedure, it might cause some pretty significant diarrhea and things of that nature. We want to encourage walking and normal activity. Like I said, showering is okay, but we don't want to get the incision soaked, so no swimming, no hot tubs, no tub baths. We want to teach our patient how to monitor for signs and symptoms of infection in the incision site, so drainage, redness, pain that's inconsistent, that kind of thing. Now, with an open cholecystectomy, this is when we actually have to make a rather large incision in the abdomen and then resect the gallbladder. This is not the preferred method because healing time, hospital time, complications are greater. Sometimes what will happen is they will go in and start with a laparoscopic cholecystectomy and then find that they cannot be successful that way, and so they'll convert to an open cholecystectomy. So this means the patient's going to have a large, probably midline-ish abdominal incision. The patient's going to have more pain. Their diet is going to be restricted, probably a bit more, and their recovery time in the hospital is going to be longer, probably 3 to 7 days for many patients. It's more common to have to do an open cholecystectomy if a patient has had multiple previous abdominal surgeries, if there's a lot of scarring in the abdominal cavity or adhesions, if the patient is morbidly obese, or if they are experiencing peritonitis. Once the patient comes back from surgery, again, pretty standard surgical care in terms of monitoring for signs and symptoms of, complications with surgery. One to be very cognizant of here in this situation would be dehiscence or evisceration because of the location of the incision, while we're taking into account body habitus and risk factors that increase the likelihood of an open cholecystectomy. Normal criteria, for moving along. The patient's got to have some sort of evidence of intestinal motility. Primarily, what we're looking for is the passage of flatus. They'll probably be started on clear liquids once there's evidence of intestinal motility, and then they'll be advanced as tolerated. During that time, from immediate postoperative period until evidence of intestinal motility, the patient might not be on any oral meds or maybe NPO, things like that. But once we start to see that evidence that the bowels are starting to move and things are working down there, then they can be placed on oral meds, which again is something that is good for them because they can go home once their pain is controlled with oral meds. Let's see, no nausea. We want to see no nausea, tolerating foods, taking in sufficient liquids, urinating, they're passing flatus, they're ambulating. All of those things are moving them towards being able to go home successfully. Think back to our perioperative care and our postoperative complications there with things like pneumonia, DVT, PE, dehiscence, evisceration. All of those things completely apply to a patient who's had a cholecystectomy. We do want to teach our patient signs and symptoms of infection, just like with the lap chole. We want to teach them about low-fat diet. We also want to include education about preventing constipation. This is good, especially in that fresh post-op period, because if a patient becomes constipated, which they might if they're taking like opioid pain medications, then it causes increased pressure in the abdomen when they're straining, which could lead to dehiscence or evisceration. So it might be good practice for the patient to make sure they're eating plenty of fiber in their diet or including some kind of stool softener to help prevent constipation because of those medications and decreased activity and things of that nature. All right, I think we've made it to the end of our discussion on, what is this, gastrointestinal function? So thank you for listening. As always, if you have any questions, please feel free to reach out.